So, a very good evening, everyone. So, I welcome you all to this particular YouTube session. So, in this session, I will be discussing the management of diabetes mellitus. Right? I will be discussing the management of the diabetes mellitus. So, that is a current topic in this session. Now, in the management of diabetes mellitus, right, you need to be aware of the management of both type 1 and as well as the type 2 diabetes mellitus. Okay, now first let me take up the discussion of the general management in these individuals. That means what is the lifestyle modifications, right? What is the lifestyle modifications that you need to consider in the treatment of diabetes mellitus? Okay, now lifestyle modifications, remember, lifestyle modifications, these are the first line treatment, right? This is the first line treatment for diabetes mellitus, right? This is the first line treatment for diabetes mellitus. Which one? The lifestyle modifications. Now, can anyone tell me what does this lifestyle modification includes? Yes, any one of you, please. What does this lifestyle modifications include? Now, let me tell you what does this lifestyle modification includes. Lifestyle modification, it includes the following. Number one, the exercise. And number two, the diet. Right? Number two, the diet. So these are the two important things as the first line treatment. Right? These are the two important things as the first line treatment. Very good, Aniket Raj. Now, coming to the exercise. What is the role of exercise? Right? What is the role of the physical activity or exercise in the management of these patients with the diabetes mellitus? And how much physical activity an individual has to do? Remember, the physical activity that has to be done by the individual, it includes, right? It includes 30 minutes of brisk exercise, right? It includes 30 minutes of brisk exercise, and that has to be done for 5 days, right? 30 minutes of the brisk exercise that has to be done for nearly around 5 days. Now, what is the purpose of doing this particular physical activity or exercise in the individual? So, the physical activity, what it will do is, it will improve the GLUT4 receptors, right? It will increase the GLUT4 receptors on the target tissues, right? Very good, Arya Ajesh. So on the target tissues, there will be increase in the number of the GLUT4 receptors. Now, what are the target tissues for the insulin? What is the substance that will act on the GLUT4 receptors? The substance that will act on the GLUT4 receptors is the insulin, right? The substance that will act on the GLUT4 receptor is the insulin. So insulin is the substance which will act on the GLUT4 receptors. Now, what the insulin will do by acting on the GLUT4 receptors? By acting on the GLUT4 receptors, it will cause the absorption of the glucose into the target tissue. Right? It will cause the absorption of the glucose into the target tissues. Now, what are the target tissues? Right? So this particular target tissues, it includes skeletal muscle, right? It includes the adipose tissue, right? And it includes the liver. So these are the target tissues for the GLUT4 receptors, right? These are the target tissues for the GLUT4 receptors. That means on which the insulin will act. So now thereby what will happen? Once the GLUT4 receptors are increased, more and more absorption of the glucose will occur, and thereby the glycemic status will get controlled. That is the advantage of that is the advantage of the physical activity, right? That is the advantage of the physical activity. Okay, next, the other important thing what is very much advised is the diet. So this particular diet, what you have to give in an individual is the low carbohydrate diet. Right, so if you take diet, the diet should contain a low carbohydrate diet and as well as the low fat diet. Right, low carbohydrate and as well as the low fat diet. Okay, now this is the diet that has to be supplemented in diabetic patients. Now the general management, that is the diet and as well as the physical activity, is one and the same for diabetic patients, either type 1 diabetes mellitus or type 2 diabetes mellitus. But in case of type 1 diabetes mellitus, you have to give insulin. Whereas in type 2 diabetes mellitus, right, in case of type 2 diabetes mellitus, you need to give the oral hypoglycemic agents. Right, you need to give the oral hypoglycemic agents. So this is the treatment in case of the diabetes mellitus. Type 1 diabetes mellitus, insulin. Type 2 diabetes mellitus, the oral hypoglycemic agents. Okay, now let me discuss in detail. And the other important thing, the other important thing what you need to know is the weight reduction is also very important in the management of the diabetes mellitus. Now, what are the recommendations? How much weight reduction should be there? The weight reduction as little as 4 to 7%, right? Weight reduction as little as 4 to 7% of the weight reduction is very much advised. Now, what is the advantage of this particular weight loss? The advantage of this particular weight loss is it will improve the insulin sensitivity. Right, it will improve the insulin sensitivity. That is the advantage of this particular weight loss. And how much of the weight loss that is advised in mainly type 2 diabetic patients? 4 to 7% of the body weight loss is very much advised. And this weight loss is very much advised in case of type 2 diabetic patients. Now the question is why? The question why is because these type 2 diabetic patients, they are obese individuals. Their BMI is very high. And in these obese individuals, they have insulin resistance. Right? They have this particular insulin resistance. Now, once the weight loss occurs, right? Once the weight loss occurs, then there will be improvement of the insulin sensitivity. Right? There will be improvement of insulin sensitivity. Okay. And how much of the weight loss is very much advised? 4 to 7% of the body fat, that has enormous effect on the peripheral insulin sensitivity and reduction of the postprandial hyperglycemia. Right? And regarding the advantage of the exercise, already I have discussed. Right? Regarding the advantage of the exercise, already I have discussed. And always remember, the exercising muscle, this is another important point what you need to know. Exercising muscle, it does not require insulin. right? Exercising muscle, it does not require insulin for the absorption of the glucose. Whereas you take the resting muscle, this is very important point that you should know. Resting muscle, it requires insulin for the glucose absorption, right? It requires insulin for glucose absorption. So this is another very important point that you need to remember. Okay. Now the next important thing is the individual is diabetic, right? The confirmed case of diabetic. Now, this particular, I said you, the first line treatment is what? The first line treatment is the lifestyle modification. With the help of this lifestyle modification, you have to observe the individual for nearly around 1 month, even though the individual is diabetic. Now, if this lifestyle modification controls the blood sugars, right? If this lifestyle modification controls the blood sugars, then in such case, right? Then in such case, please remember this very, very important point, continue lifestyle modification if it controls the blood sugars. But if the lifestyle modification, if it is not controlling, right? Please remember this point also. If the lifestyle modification, if it is not controlling the blood sugars, that is the point when you need to add the oral hypoglycemic agents if the individual is type 2 diabetic. Right? That is the point when you should add the oral hypoglycemic agents. Okay. So that is about the importance of the lifestyle modification. Now, I said you, the lifestyle modifications, whenever they are not controlling the blood sugars, you need to add oral hypoglycemic agents. Now, which oral hypoglycemic agent should be added first? If the individual is type 2 diabetic, which oral hypoglycemic agent has to be added first? Remember, very, very important point, metformin is considered as the drug of choice. Right? Metformin, it is considered as the drug of choice. And what is the quantity of the metformin that has to be given? The quantity of the metformin that has to be started is 500 milligrams. Right? The quantity of the metformin that has to be started is 500 milligrams. Okay. And what is the maximum dose of the metformin that can be given? The maximum dose of the metformin that can be given per day is up to 3 grams. Right? The maximum dose of metformin that can be given is 3 grams. Now, what is your metformin? Which class of oral hypoglycemic agent is your metformin? Metformin, remember, it is a biguanide. Right? Remember, metformin is a biguanide. Now, what this metformin will do? Metformin will reduce the blood glucose. Right? Metformin will reduce the blood glucose. How it will reduce the blood glucose? It will reduce the blood glucose by inhibiting the hepatic gluconeogenesis. Right? By inhibiting the hepatic gluconeogenesis. That is what the metformin does. That is what the metformin does. So metformin, it inhibits the hepatic gluconeogenesis. Right? Now, the next question is, we have many oral hypoglycemic agents, right? Right? We have many oral hypoglycemic agents. Even then, why metformin is considered as the drug of choice? Right? Even then, why metformin is considered as the drug of choice? Why? Because metformin will cause maximum reduction of the HbA1c. Right? Metformin will cause maximum reduction of the HbA1c. And that is the reason why metformin is considered as the drug of choice. Right? That is the reason why metformin is considered as the drug of choice. Okay. Now, how much is the HbA1c that is reduced by the metformin? Right? How much is the HbA1c reduced by the metformin? Metformin will decrease the HbA1c by 1.5 to 2%. Right? Metformin will decrease the HbA1c by 1.5 to 2%. That is the maximum HbA1c reduction which is being done by the oral hypoglycemic agents. Like we have various classes of oral hypoglycemic agents. We have sulfonylureas, we have biguanides, right? And we have alpha glucosidase inhibitors, right? And then we have thiazolidinediones. Then we have DPP4 inhibitors. Then we have GLP-1 analogs. Then we have SGLT2 inhibitors, right? Then we have SGLT2 inhibitors. So these are all the various classes of oral hypoglycemic agents. But still, why do we consider metformin as a drug of choice? Because among all these oral hypoglycemic agents, metformin is the drug which will cause maximum reduction of the HbA1c. That is the reason why metformin is considered as the drug of choice. Okay, so it will reduce HbA1c by almost 1.5 to 2%, right, within 3 to 6 months. Yes, Achan Khan, good evening. Then, what is one more advantage? Sorry. The other advantage of metformin is, right, the other advantage of the metformin is, this metformin will also cause the weight loss. Right, this metformin will also cause the weight loss. That is the advantage of the metformin. Okay, so what the metformin will do now? Metformin will reduce the BMI of the individual. Right, metformin will reduce the BMI of the individual. That is what the metformin does. That is the added advantage of this particular metformin. But one important point you should remember is that metformin, it is contraindicated in case of renal failure. Right? Metformin, it is contraindicated in case of the renal failure. Okay? Now, why is it contraindicated? Why? Because metformin, it is excreted via kidney. Right? Metformin, it is excreted via kidney. And this metformin, it is contraindicated in those individuals whoever has renal insufficiency. Now, the next question is, suppose if metformin is given in patients with the renal failure, right? For suppose if metformin is given in patients with the renal failure, then what it can do? Then the individual will land up in what is called lactic acidosis. Right? Then the individual will develop what is called lactic acidosis. So lactic acidosis is the complication that can be developed if there is renal insufficiency. Right? If there is renal insufficiency. Okay. So then the next question is, if there is renal failure, then what is the alternative drug that can be given? Right? If there is renal failure, then what is the alternative drug that can be given? If there is renal failure, remember the alternative drugs that can be given is linagliptin. Right? Linagliptin is a DPP4 inhibitor. Right? Linagliptin is a DPP4 inhibitor. And this linagliptin, remember, it is metabolized by the liver. It is metabolized by the liver. And that is the reason why we can give this particular linagliptin. Okay? So L for linagliptin, L for liver. Right? L for linagliptin, L for liver. Okay? So in renal failure, you can give linagliptin. Now, what are the other drugs that can be given in case of nephropathy? The other drugs that can be given in nephropathy is glipizide and as well as the tolbutamide. Right? Glipizide and as well as the tolbutamide. So these are the drugs that can be given in nephropathy. Right? These are the drugs that can be given in nephropathy. Okay? Why? Because these are the drugs which are metabolized by the liver. Right? These are the drugs which are metabolized by the liver. So that is the reason why these drugs can be given in patients with a renal failure. So now to summarize the things, whatever I have taught, if the individual blood sugar is not controlled with lifestyle modification, the drug of choice in type 2 diabetics is metformin. Metformin is a biguanide. Metformin, it is having an added advantage of causing the weight loss. Metformin, it will reduce the blood glucose levels by inhibiting the hepatic gluconeogenesis. Right, by inhibiting the hepatic gluconeogenesis. Okay, and the next important thing is metformin. This is a very, very important point. Metformin will never cause hypoglycemia. Right, metformin will never cause hypoglycemia. That is another advantage of, right, that is another advantage of the metformin, will never cause hypoglycemia, right? And the next summarizing point is metformin is metabolized in the kidney and it will be excreted through the kidney. And that is the reason why metformin should not be given in patients with the renal failure. Then what is the drug you will give in case of renal failure? You can give linagliptin, you can give tolbutamide, you can give glipizide. Why? Because the other drugs, they are metabolized by the liver. Right, next. Now, what are the other important adverse effects associated with the metformin? Metformin will also cause vitamin B12 deficiency. Right, metformin will also cause vitamin B12 deficiency. That is another important adverse effect of metformin. Right, another important adverse effect of metformin is vitamin B12 deficiency. Okay, next. And we have another biguanide. The other form of biguanide is your fenformin. Right? Yes, Mohammad Faizan, good evening. I'm fine, Mohammad Faizan. How about you? How are you? Right. So this biguanide, other biguanide, apart from your metformin, is your fenformin. This particular fenformin is completely removed from the market. It is nowhere used. Why fenformin is removed from the market? Why? Because this fenformin, it has a very high incidence of lactic acidosis. Right, it is having a very high incidence of lactic acidosis. Okay, and this lactic acidosis, it is of two types. That is type A and as well as type B. Right, type A and as well as type B. And this fenformin, it will cause type B lactic acidosis. Right, this will cause type B lactic acidosis. That is what is the adverse effect of fenformin, and that is the reason why that is being completely withdrawn from the market. Right, and what is the advantage of the metformin? I have said you, metformin will never cause hypoglycemia. Metformin will also cause weight loss. That is the advantage of the metformin. Okay, you are giving metformin. Right, you are giving metformin. So with metformin, if the blood glucose is not controlled, right, with metformin, if the blood glucose is not controlled, then what is the alternative drug? What is the alternative drug? The alternative drugs are sulfonylureas. The alternative drugs are the sulfonylureas. Now, this particular sulfonylureas, remember, they are your insulin secretagogues. Right, they are insulin secretagogues. Yeah, yes, Aniket Raj. That is the advantage of metformin. Even though you give metformin in a very high dose, it will not cause hypoglycemia. Right? Even you give 3 grams of metformin, it will not cause hypoglycemia. Okay? The reason is very simple. What is the mechanism of action of metformin? It will inhibit the hepatic gluconeogenesis. What is gluconeogenesis? Conversion of a non-carbohydrate moiety to the carbohydrate moiety. Right? Conversion of non-carbohydrate moiety to the carbohydrate moiety. That is what is your gluconeogenesis. So when you are giving a high dose of metformin, what it will do? It will inhibit the conversion of non-carbohydrate to carbohydrate, but it will not do anything to the glucose level which is already present within the blood. And that is the reason why it will not cause hypoglycemia. right? That is the reason why it will not cause hypoglycemia. Okay. Yes, Aniket Raj, is that clear? Right. Now, you are giving maximum dose of metformin, right? You are giving maximum dose of metformin. In spite of giving maximum dose of metformin, if the blood glucose is not controlled, right? In spite of giving maximum dose of metformin, if the blood glucose is not controlled, then in such case, you need to add sulfonylureas, right? You need to add sulfonylureas. Okay, and this sulfonylureas, remember, they are insulin secretagogues. Right, they are insulin secretagogues. Now what they will do? They will stimulate the beta cells. Right, they will stimulate the beta cells. And these beta cells, they will release the insulin. Right, these beta cells, they will release the insulin, and thereby they will reduce the blood glucose. Thereby they will reduce the blood glucose. That is what the sulfonylurea does. That is what the sulfonylureas does. And if you take this sulfonylureas, these sulfonylureas, we have two types. First generation sulfonylureas and as well as the second generation sulfonylureas. Okay, first generation sulfonylureas, we are no more using this now. Now the question is why? Why? Because these first generation sulfonylureas, remember, they will cause profound hypoglycemia. Right, they will cause profound hypoglycemia. Okay, that is the disadvantage of first generation sulfonylureas. And what is the examples of your first generation sulfonylureas? That includes chlorpropamide and as well as the tolbutamide. That includes chlorpropamide and as well as the tolbutamide. These are your first generation sulfonylureas. Then we have the second generation sulfonylureas. What are second generation sulfonylureas? They include glibenclamide, glimepiride, glipizide, gliclazide, and then gliburide. So all starting with G, right? All starting with G. That is your second generation sulfonylureas. And all of them, they are insulin secretagogues. All of them, they will increase the insulin levels within the body. So this is about your sulfonylureas. So by the discussion of your biguanides, that is metformin, I will just wind up the session today. Tomorrow, we will discuss the other types of oral hypoglycemic agents, and in detail, we will discuss the treatment of type 1 diabetes mellitus also. So with this, I'm winding up this particular session. So what is the summary of this session? Lifestyle modification, that is number one. Number two, drug of choice in type 2 diabetes mellitus is metformin. So these are the two things like what you're learning today. And tomorrow, I will continue with the remaining part of the management of your diabetes mellitus. Thank you very much and see you tomorrow again. And if you have any doubts, you can post. Definitely, I'll be very happy to answer your questions.